Thank you very much, sir. I have the honor of introducing Dr. Sujay Subramanian. Dr. Sujay Subramanian has over 30 years of experience in psychiatry as a clinician. He is also currently heading the Ashiana Psychiatric Care Hospital in Chennai. He has done his MBBS from Ramaya Medical College, Bangalore, and his post-graduation MD in psychiatry from the prestigious Armed Forces Medical College in Pune. His interests besides psychiatry also include brewing coffee and traveling. So it's a big honor to welcome you, sir. And may I request you to please begin with your presentation. Thank you, sir.
Thank you. So, respected chairpersons, esteemed colleagues, hi, good afternoon. My name is Dr. Sujay Subramanian. I'm a psychiatrist practicing in Chennai, and I'm going to speak a little bit about behavioral treatment, substance abuse, and the newer developments. When we talk about ourselves as clinicians, we like to think of ourselves as biological psychiatrists. That is, when somebody comes to us with a problem, we like to think of it having a biological, the disorder having a biological basis. When someone comes to you and tells you that I am hearing voices, we want a biological basis for that. Like, okay, there's a dopamine disturbance, and then we would like to offer a biological solution to that. We give them an antipsychotic, and then we correct the neurotransmitter disturbance, and then thereby brings about some improvement. So the whole thing has got a biological basis, and this somehow makes it very scientific. But when we talk about behavioral treatment, then we don't have this kind of a basis. But there are reasons, and some of them are very interesting, and sometimes even fascinating explanations are there. But they're very scientific. They are not measurable. They're not reproducible. So sometimes we wonder about the efficacy, and we wonder whether we can replicate this in, if you can do it in one patient, can we replicate this in another patient? So because it's not scientific in terms that we are used to, there's always some question about whether this will actually do what it's supposed to do. But I want to say that the lines are blurring between these two. The understanding of how behavioral therapy works is improving day by day, and I'm going to get to a place where we understand this a whole lot better. So why did we choose behavioral treatment in substance abuse? Well, because for one thing, substance abuse is a massive problem. It's a massive problem. So according to the United Nations Office on Drugs and Crime, there is over 35 million people having substance abuse and who requires treatment now. It's not people who are having substance abuse problem, because these are the people who require treatment now. And the US, it costs them over $600 billion annually. Now this is to put things in perspective. India has spent $10 billion on getting all the 35 Rafale jets. So $600 billion is what it costs because of substance abuse in the US. So we can see that this is a huge drain on human life as well as a huge drain on resources. So let's say when you come to addiction, it doesn't. I mean, when you start taking drugs, you don't. It's not like you have no control over it. You have a lot of control over it. You take it because of peer pressure, or because you want to have a good time, or because you're experimenting. There are a whole lot of reasons, but you choose to take it because you want to take it. But over a period of time, the ability to choose goes away, because you are no longer you no longer have control over it. Seeking and taking drugs becomes a compulsive act. And so what happens is that because over a period of time, addiction takes over, and addiction affects parts of the brain involved in reward, motivation, learning, and memory. So what happens is you kind of lose control over behavior. So it would be fair to say that addiction is actually a disease both of the brain and of behavior. What is behavior? The behavior is the way in which a person behaves in response to a particular situation or stimuli, or the reaction of a person in response to an external, internal stimuli. Now, behavior is not just confined to humans. Behavior is what individuals, organisms, systems, and even artificial entities show. It is the computed response of organisms or systems to various stimuli, whether it's internal or external, whether it's conscious or subconscious, overt or covert, voluntary or involuntary. Now, so what is normal behavior? Of course, there are two ways of looking at normal behavior. The first one is normal behavior that is consistent with the person. if I'm talking about a thief, and if you were to steal something, if it's possible to bring more. So what happens is you kind of lose.
Yes, someone is talking. Hello, someone is talking.
Is the way in which a person behaves in response to a particular situation or stimuli, or the reaction of a person in response to an external internal stimuli. Now, hello.
Yeah, please go on, sir. Please continue.
So when you talk about normal behavior, so normal behaviors, there are two ways of looking at normal behavior. One, that is the behavior that's consistent for a particular person. So if I'm going to talk about a thief, and if he goes and steals something, that would be considered, I know I'm being politically incorrect, but that would be considered normal behavior for that person. Now, but that would not be normal behavior for society, because for society, that is not the right thing to do. That's the wrong thing to do. It may be normal behavior for a thief, but it's not normal behavior for society. So in society, conformity is important. So simply put, normal is good and abnormal is bad. And this is actually very important because it's got significant social ramification. Because if you're normal, you're included, and if you're not, you're rejected. So what is abnormal? Sorry. So let's come to behavior therapy. Behavior therapy came onto its own in the mid 1950s with Skinner and operant conditioning. But of course, these theories and systems have been around for ages before that, for years, maybe decades before that. After Skinner and operant therapy, came into being. Behavior therapy actually is an umbrella term for a certain set of therapies that treat several mental health disorders. Now, what this therapy does is that it seeks to identify and change potentially self-destructive or unhealthy behaviors. It functions with the idea that all behaviors are learned, and that means unhealthy behaviors can be unlearned and changed. That means the problem that you face is because of an unhealthy behavior, and that unhealthy behavior can be unlearned and thereby make you feel better. So now in substance abuse, how does it help? So there are various ways. There are different kinds of therapies, and different therapies do different things. It's not that one therapy would do everything. So there are different therapies, and we can engage them depending on the kind of situation that we have. So in substance abuse, behavioral approaches help in several things. One, it engages people in drug abuse treatment. So one of the problems that we have with drug abuse is that a lot of people don't stick to treatment. The dropout rates are very high. People have no interest in continuing to take treatment. They want to go and take the drug. So the behavioral therapy helps in engaging them in treatment, provides incentive. One of the therapies provides incentive. Now, getting incentives is good for some people because they have some reason to stay back in therapy. It modifies attitudes and behavior, which of course is the mainstay of behavior therapy. It helps increase their life skills in handling stressful circumstances. Also, how to trigger, how to control the environmental cues that trigger them. Trigger craving. So behavioral therapy helps in various things. And depending on what the person needs most, we should be able to employ what kind of therapy we need. And so what are the different kinds of therapies that we have? So we have several therapies that we use, and this by no means is an exhaustive list. I've just taken the most popular ones, and I'm going to just quickly go through these things. So the most popular is, of course, contingency management, then CBT. CBT is across the board the most popular form of behavior therapy, community reinforcement approach, motivational interviewing or motivational enhancement therapy, mindfulness-based relapse prevention, matrix model, come to that, and the 12-step facilitation therapy, which is, of course, what Alcoholics Anonymous follows. So let's come to contingency management. Now, this is a very easy therapy to set up because you don't need anyone with any great knowledge. The whole thing is, okay, you stay clean and we give you a reward for staying clean. So it's based on the principles of operant conditioning, in which a behavior that's followed by a positive consequence is likely to be repeated. So we give him a positive consequence. That is, he stays clean, we give him a reward. Hopefully, over a period of time, that behavior, which is staying clean, will be repeated. So there are two ways of doing it. One is voucher-based, another is price incentive. Voucher-based is for remaining clean, you're given a voucher, which can be in exchange for maybe, I don't know, food, or he can buy something that he wants. And the other one is price. Now, prices are cash prices. Of course, there is a lot of interest in people getting cash prices because, cash has got more, the lure of cash is much more. People want to get cash. But the problem with cash is that it can also be used to buy whatever he wants. If it's a voucher, he can only get particular things with the voucher. You can't just go and buy, let's say, you can't go and buy drugs with that. But when it's cash, we don't know what he's going to go and use it for. So while cash price incentive CM is more effective, voucher base is probably safer. Now, while this has been very, very popular, it's also got a whole lot of limitations. So the first thing is that the minute the contingency stops, the effectiveness seems to come down. So no more rewards. What is the point, and why do I need to keep myself clean? The second is it's an expensive process. You got to give all these rewards. You got to have all these people keeping an eye on them, seeing if the guy is clean, if he's maintaining. So it's a lot of people that's required to be working over here. And in countries where, of course, in India, because we have a lot of people available, it's not so bad. But in countries where people are limited, this would be a very expensive option to have. The second and the third thing is that a substantial, because this does not have any other therapy in it, a substantial proportion of the people do not respond to it at all. Let's say somebody who is reasonably well off and does not need all these vouchers and cash incentives, this is not going to work for them. And also people who have issues, other issues, where you're not working through any of the other issues, does not work for them either. So a substantial proportion does not respond to contingency management. So while it's good, it's got severe limitations. Let me come to CBT. Now, CBT, like I mentioned earlier, across the board, it's the most popular form of therapy, period. CBT, of course, works on identifying disturbing thought patterns and which have an influence on both behavior and emotion. And for several conditions, CBT has been considered to be very, very effective. Now, a couple of offshoots of CBT which has become very popular in substance abuse is one is DBT, or dialectical behavior therapy. Now, dialectical, the word means logical discussion of ideas and opinion. And this was actually started as a therapy for borderline personality disorders, a condition for which we really had no treatment at all. And DBT had started to be kind of useful over there. It was also used in crisis situations, like when you have a severely depressed person with severe suicidal ideation. DBT was actually something that we could intervene at that point of time. So then, so the main goal is how to live in the moment, how to develop ways to cope with stress, and how to regulate the emotions. The other one is rational emotive therapy, rational emotive behavior therapy. It involves identifying irrational beliefs, challenging them, and then recognizing and changing these patterns. So both of these have been quite useful offshoots of CBT, which has been very, very well usefully applied in substance abuse management. The community reinforcement approach. Now, this again, it is not very common in India, but it's very common in the West. Originally only for alcohol dependence, now being used for a variety of substances, again, based on operant conditioning. So what you do is that you make sure that the person who's come back after, after a life as a substance abuser, now he comes back and he has what is called a normal life. He has a family and he's part of the community and he's an important member of society, and people are there to support him and help him and look up to him. And as a result, and so what happens is that this particular life that he has becomes so good that he starts competing for his earlier alcohol and drug use life. So the whole idea is that this is so rewarding that he will hopefully not go back to the other one. Two very important offshoots of CRA, which has been very useful, again in the West, not so much here. One is adolescent CRA, and the other is something called craft. So adolescent CRA is where they just it's the same as community reinforcement approach, just that they target only adolescents, because adolescents are a very very difficult set of people to manage, and so they started having a separate segment treating or addressing only adolescents. Again, this has proved to be very, very useful. And craft is community reinforcement approach and family training. So here what they do is that they've been using the family to approach a member who's probably not very interested in remaining clean. And they found that when you use family members, it's also been much more useful. So again, you're using the whole community and using family, and you're able to create a situation where they can live a life without substances. So motivational interviewing. So now this is this is a counseling approach where you actually do not confront the person at all, and it is actually to tackle ambivalence a person may have. So when somebody is if you have been using the substance for a while, when you try to stop it, there's a lot of ambivalence that goes on. I mean, should I stop it or not? Can I take it for a little while longer? There's a lot of ambivalence, and then what happens is MI helps in overcoming that. So typically, it's followed by initial assessment, followed by 2 to 4 sessions with a therapist, and this can be used for strengthening motivation and building a plan for change. This is something that we have been using, and it's been very well appreciated. So mindfulness-based relapse prevention. Now, mindfulness is a type of meditation where you focus on what you're sensing and feeling without interpretation or judgment. I mean, that's it is a very, 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 very useful and rewarding procedure to do by yourself. So mindfulness-based relapse prevention is and it's focused on the period just after you've taken, let's say, a regular detox, something like that. So this focus on the period soon after that, because that's when you're most vulnerable for relapse. So, you come out and you have all these questions like, how do I cope with life, and what do I do when I have an urge, and how should I fight it? And mindfulness-based relapse prevention helps you cope with all these situations. The matrix model is actually a very structured 4-month or a 16-week model that it is essentially used only for stimulants like cocaine and methamphetamine. It's been it's a very structured. It's an outpatient model, but the person has spent the whole day in the treatment center, and then he goes back home in the evening. It's been very successful. It's been very successful, but it's I'm not sure how great a model it is, but it's been a very successful model, and so I had to put it in because it's one of the most successful models that we have had. So essentially within the 16 periods, they learn how to avoid relapses and how to socialize in a drug-free environment. The 12-step facilitation therapy. Now, this is something that we are all used to. This is what Alcoholics Anonymous has been doing, and it's been available in all over the world, in India for so many years now. There are 3 key ideas that play over here. First one is acceptance. Second is surrender, and 3 is active involvement in the 12-step meetings. So this has been going on for a long time. Now, we know that Alcoholics Anonymous is a very successful group, and of course, it has been very, very useful in treating alcohol dependence. But the success could not be replicated in various other things. And I know that Narcotics Anonymous also is it's quite active, but it's not been as successful as Alcoholics Anonymous. So now we're coming to that. So let's say, behavior therapy. So we've seen that behavior therapy can be used. Several types of therapy is there. They can be used in different kinds of patients, and we must choose what each person requires, and we should be able to tailor make that for them. But in spite of that, there are a lot of pluses and minuses that we need to know about behavior therapy. First is that in spite of the great advances pharmacotherapy has made over the years, we still use behavior therapy, and they've become and they're an important component of various substance abuse disorder treatments. And well-established treatments like CBT and contingency management have continued to be extremely effective. But the problem is that they're the cost and resources are too much, and probably it's not the return on investment is not enough because of the high cost and high resource that needs to be used for this. So in the initial stages, in the 60s and 70s, when psychotherapeutic methods were being used, there was no evidence whether these are really useful or not. People use them, but you don't know whether it's really working or not, because there was no way to evaluate them. But later on, experimental methods came through, and then they could be, and we were able to evaluate them. So by the mid to late 80s. There were a number of established behavioral treatments that was actually efficacious for several mental illnesses like depression and panic disorders and OCD. But studies in mental health, in substance abuse disorders, were actually quite minimal. So we didn't have too much of evidence in that. So by the 80s, there were several programs that was available for treating substance abuse people. I'm talking about behavioral programs that were available. But there was a lot of pessimism because we don't know how efficacious they are, whether they work or not. We don't have any proof of whether it's going to work or not. So by the mid-1990s, the National Institute of Drug Abuse, NIDA in the United States, started offering comprehensive support, that is financial and comprehensive support for studying behavioral treatment in substance abuse. And they wanted to come up with a treatment that is both efficacious and practical. So it is something that would be useful. And so what happened then is that there was a change in focus. So what happened is, till then we would always look at which treatment can be used for treating addiction. So it's not a question of anything else. And then the focus shifted to how these treatments work, how best to implement them in a community, and what underlying factors can be manipulated to increase the success of these treatments. So there was a shift in focus as opposed to what it was all these years. And then, so what happened is then because of shift in focus, it has led to a couple of changes. So one is that they led to advances in the understanding of the mechanism of how these treatments work. And second is, it led to incorporation of technology into the delivery of current treatments. And the inclusion of neurocognitive approaches to target the automatic and higher order processes underlying addictive disorder. Now, I'm going to look at, so the last two, that is incorporation technology and inclusion of neurocognitive approaches, are the two advances in behavior therapy as I see it. And I'm going to go into both of them in some detail. I know it just sounds really vague now. I'm going to go into both of them in some detail. So initially, incorporation of technology. So now these interventions are can come in a variety of delivery formats, like computer-based or mobile phone-based or tablet, etc. And they can be for different interventions, not just behavioral therapy. It can be for brief interventions. It can also be for making sure that treatment adherence, so like a treatment adherence tool, and can be used for various substances, whether it's opioid or cocaine, alcohol, or cannabis. So various formats, various interventions, and various substances. Also, they can be used based on existing established treatments like CBT, community contingency management, community reinforcement approach, motivational. So it can be any one of them or a combination of them. Any of these already established methods can be used. Then, so it started. Then technology-based interventions started going beyond acute care into continuing care models. One of the good examples would be the system called CHESS, which is Center for Health Enhancement and Studies. And this was actually started by the University of Minnesota initially, but then it started being adopted elsewhere. So this is like an app. It's like a smartphone app. And then what it does, it offers the following. It gives you video counseling. It gives you network supports and peers. And it does momentary assessments every once in a while to see what your situation is. And then it'll give you some tailor-made interventions. Maybe like your tense and can give you a relaxation audio file. They also have something called avatar-facilitated motivational interviews. So you don't have to have a person, you can just have an avatar that's doing it. It also, what it does is it also uses GPS to track your location. So let's say you've been going into, a wrong part of town where you are in an area where drugs are easily available. And if you're there, then the system will know that you are there, and then maybe some kind of intervention can be done. So it goes on to doing a wholesome kind of management. So also other emerging technologies can be incorporated. For example, wearable and unobtrusive sensors, so like maybe a smartwatch or maybe just a band, which can actually start, sending information in real time. So that we can do in-the-moment interventions depending on what's been happening. So there are a whole lot of advantages that because of incorporation technology we've got. And they include things like, one, accessibility and availability across settings. There is consistent delivery of treatment. There's freeing up of clinicians' time, conveying information in an engaging manner. You can individualize and tailor-make the treatment for each person, and this can be extremely cost-effective. But in spite of all the great excitement and the promise of technology, it's not all good. One of the things that we are not sure if these things really work or not, because we have not had enough studies to prove that these things work. And the reason is that because, first of all, there are very few and limited studies to begin with, and many of them don't use very high quality standards. Controls are often weak, there's poor follow-up, and there is lack of attention to validity generally. So the studies, to see if these things are really working, we need to have proper studies that show us that these things are working, and we don't have that as of right now. But of course, these are initial stages as far as incorporation of technology is concerned, and hopefully more robust studies will come. So the next thing is cognitive neuroscience-based developments. So we'll just go into that in some details. So now, so the recent developments from the field of cognitive neuroscience has been contributions to one, our understanding of addiction, and two, development of new intervention and treatment approaches. So our understanding is better because we've been using methods that can study, they can study the effects of behavior therapy across an array of psychiatric disorders, including addiction. So methods have been studying function as well as structure. So functional studies include functional MRI, EEG, PET scans, and for studying structure, we've been using MRI. Now, when you look at neurocognition literally means ability to think and reason. So neurocognitive theories say that addiction is maintained by two things. One is hyperactivity of an automatic processing system and deficits in a higher order reflective impulsive processing system. I'll go into both of these in great detail. So these are two social cognitive systems. The first one is an automatic processing system. I will go into that, and the reflective impulsive processing system. So let me go to the first one first. So automatic and controlled processes, these are two categories of cognitive processing. Now, all cognitive processes fall into either one or both of these categories. An automatic process is unintentional, involuntary, effortless, and occurring outside of patient's awareness. And control processes are under the flexible, intentional control of the individual, and he or she is consciously aware of that. So the automatic process is automatic; it goes without the person's awareness. So the first thing is that it's a hyperactivity of an automatic processing system. So what we are having is this automatic process, which is one of the two processes in cognitive processing, is there's hyperactivity of that. The second one is deficits in higher order reflective impulsive processing system. So we'll come to what reflective impulsive processing system is. So reflective impulsive processing system forms a general basis, forms the basis of general theory of social cognition and behavior. This is a two-system model that explains social behavior as a joint function of both a reflective and an impulsive process. The reflective system generates behavior decisions based on knowledge about facts and values. It is flexible, effortful, requires motivation, and its operation is typically conscious. Whereas an impulsive system elicits behavior through associative links and motivational orientations. So this is like supposing you're driving down the road and then somebody cuts you or jumps in front of you, and you get very angry and you want to get up and pick a fight. So this is an impulsive system where you are behaving through associative links and motivational orientation. You're not picking up a fight based on facts and values. So what happens is what is happening now is inflexible, effortless, almost active, and this is capable of operating unconsciously. So the two models that we have. So we have deficits in higher order reflective impulsive processing system, and these are sorry. And so these are the two parts of the reflective and the impulsive system. So now what's happened is that several new interventions have been designed to target these cognitive systems. So now there are several things that we can talk about. So what I'm going to do is I'm going to just take one example so that we'll have an understanding of how this system can be, how we can manipulate the system to our benefit. So I'm going to just take one example and we'll go ahead doing that. So one area that's gained particular attention is the work on something called implicit cognitive process. Now, I'll come to what implicit cognitive processes are, and then some of the implicit cognitive processes are attentional bias and automatic actions. I'm going to come to that. So first, we'll see what implicit cognitive process is. So now, these are two levels of social cognition, that is implicit and explicit social cognition. So when you look at implicit, this is at a low level. It is a fast, relatively inflexible routine that's largely automatic and implicit, and it can occur without your awareness. The explicit social cognition, this is the other one. It's a higher level. It's slow and flexible. This requires expenditure of mental effort. This doesn't happen without your knowledge. This happens with your complete awareness. So implicit happens without your awareness, and it happens very quickly. So we are going to be targeting implicit cognitive processes, and two of those things that we're going to target in that is attentional bias and automatic action. So now we know what implicit social cognition is. So let's look at what attentional bias is. Attentional bias is how a person's perception is affected by, for example, if you're a smoker, when you go into a place, what happens is you'll immediately see where cigarette is available, which is the smoking area. But if you're a non-smoker, you're not going to be seeing all that. I remember sometime back recently we had a very important VIP who had been brought from the Northeast for for treatment for opioid addiction, and the family is extremely influential. They brought him down, and they flew into Chennai, and they checked into a hotel, and they were supposed to come and see me the next morning. So he has come in, and he's checked into the hotel, and by the time they go to sleep, he's completely blown. So the parents said that he had no substance with him when he was coming in, but what he had managed is that by the time he managed to get into the room, they checked in and got into the room, he was able to, because of his attentional bias, he was able to look for opioid-related cues around him and get the substance in that five-star hotel and take it before he could go to sleep. So now, why are we looking at attentional bias? Because there's evidence that a variety of implicit cognitive processes, like attentional bias, memory bias, and at a neural level, cue reactivity, are all associated with substance abuse. So if we know that this is associated with substance abuse, can we use that to our advantage? So how do we do that? How do we use this information to our advantage? So we can use it to advantage because we now understand that some of these implicit processes, the effect that they have on addictive behavior, can be moderated by certain things. So that means what can this moderate? So executive functions can moderate them. So okay, in that case, then how can we work on that? So this is an example of how we are going to manipulate an implicit cognitive processing system. So we're going to look at something called training on working memory. So we are taking working memory and we're going to work on that. So why are we looking at working memory? Because from a neurocognitive perspective, when levels of executive function such as working memory are low, substance abuse behavior is guided most strongly by impulsive automatic process. So now these are the two things that we want to cut down. So if you strengthen working memory, as well as other executive functions, then the individual would be able to gain more cognitive control, thereby avoid impulsive behavior and substance use consequently. So now here we have looked at just one thing, which is working memory. And the reason why we looked at working memory is because there's strong evidence that working memory can be improved through training procedures. So this is something that we know we can work on, and we know this can be changed. So once we change this, then there is an effect on the person. The second thing is working memory also shows improvement in delay discounting. Now, delay discounting is another big problem that a lot of people with addiction have. So most of us are willing to delay gratification. So let's say if I say you work now and you get paid at the end of the month, we are willing to do that. We will work now because we know that at the end of the month you get paid. We're willing to wait for that. But for a substance abuser, he wants the gratification immediately. The more you delay it, the more he discounts it. But when your working memory has been, when you're training on working memory, it has been demonstrated that delay discounting goes down considerably. That is, they are willing to actually delay gratification. So in several ways, just working on one executive function improves the ability of the person to stay away from substances. So if we can work on other executive functions, if we can work on other cognitive factors, then the effect of it can be much more. Can be much more.
Petrol on the petrol deal.
So in conclusion, I would like to say that developing neuroscience-based interventions from neurocognitive theories of addiction is still an emerging area, but the results appear very promising. As our understanding of interaction between implicit learning mechanisms and high-order cognitive processes become more sophisticated, so too will be the types of interventions. However, in spite of all the advances made and the integration of technology-based formats, behavior therapy, and other such interventions are for now still to be delivered as a supplement to standard substance abuse treatment. It can't be the main thing. But expanding our understanding of addiction beyond traditional behavior therapies by incorporating neurocognitive theories will advance the field more towards more comprehensive answers to the question of effective management of substance abuse. So before I end, I want to talk about this person over here. His name is Andy Warhol. He was, a great painter, sculptor, movie director, and somebody who had actually struggled with substance abuse his whole life. He used to use substance an amphetamine product called Orbitrol, which was actually a weight loss product, but he was addicted to it. And he had actually He was someone, a great believer in behavior therapy, and he used to be in behavior therapy for most of his life. These are, in fact, he's got the largest single museum dedicated to a single person in the US. He's got thousands of his works are there. This is probably his most famous silk screen painting that he's got of Marilyn Monroe, which is currently worth well over $100 million. And he's an often quoted person, and one of his most quoted sayings is that people should fall in love with their eyes closed. There's a whole lot that I could talk about him, but I would like to end by saying, so this is again a cartoon that's been done by Andy Glassberg, and in the Syndicate strip. So he says, I've got a very good solution. Now I just need to find a problem to fix, to go with it. I hope by all the advances we make will not come to that. Thank you so much. I don't know how to get out of this now. Okay. So you're muted.
Okay, sir. Now I am audible, I think.
Yes, sir. Yes, sir. Yes, sir.
Thank you, sir, for your lucid and informative presentation. And you covered from the normal behavior to the principles of behavior, and technology-based interventions, and cognitive neuroscience-based developments, and all the things you covered in recent advances. Thank you very much, sir.
Thank you, sir.
And you also concentrated on implicit and explicit social cognition, and on working memory also.
Yes, sir.
Madam, do you have any? You want to talk anything about this? Darpan Kaur, madam. Madam, she's not here. Hello?
Dr. Darpan Kaur, can you hear us?
Yes, sir.
Please unmute, madam.
She's unmuted.
Please unmute.
Dr. Sujay Subramaniam, it's been a wonderful lecture listening to you, and you have concise all the information available very, very well. So thank you so much for your very excellent lecture. And can we proceed to some question and answers?
Are you able to see the madam questions? Hello?
I'm not sure there are questions. If they're there, it would have come up in the chat. I don't see any questions.
Yes, I'm also unable to see any questions. So I'd like to ask you one or two questions, Dr. Sujay Subramanian. Yes. So I think that you have highlighted a lot about technological and digital options as well in your presentation. So I think that now, considering the pandemic, there has been a lot of development of apps and individual interventions for, say, sleep and depression and anxiety. So what are your thoughts about individualized interventions over digital mediums, or this what is the future of digital and behavior therapies for addiction? Thank you.
So I think digital would be the way to go in the future. I mean, if you're asking me whether that's better than a face-to-face interaction, no, of course not. It's not. But given the circumstances and the way the situation is going, it is going to be the way that's done. I mean, so I have only done online consultation for the past 1 year. I have not seen a patient live for the past 1 year. And I'm seeing all my patients, and many of them are quite happy. Of course, some of them do want to see me face to face, but that's the thing. And many of these apps can be absolutely wonderful. I mean, they are so useful. And the thing is that they bring in so much information, and there is so much of innovation there. I've seen many of these apps, and I think they're going to stay. I don't think the pandemic really had a very great role to play in this. It did give it a slight push, but I don't think it had a very great role to play. It was already going this way, and because of cost effectiveness and availability and the ease of being able to give it to a whole lot of people. So I think it was already going this way, and I think that's the way to go. And I think it's a wonderful way to go as well, because a whole lot more people are going to get it. It's going to be more useful. We can spread it across a whole lot of people. It's very cost effective, and it's going to be very effective, I feel.
Thank you very much, Sujay. Yes.
Sir, I have one question. Sir, what is the role of cognitive enhancers in improving the working memory and executive functions?
I'm sorry, sir. What's the role of?
Role of cognitive enhancers.
When you say cognitive enhancers,
improving the executive function and working memory.
You're talking about medication?
Medication, yeah.
Medication. So I did come across something, but I don't think that really plays a role. So I did come across something, but because I couldn't find anything that really establishes in any way, so I didn't even bring it up. I didn't even mention it. So I did read up a little bit about that, but I don't think it plays a significant enough role. So.
Okay. Is there any role of physical exercises?
Oh, absolutely. I should have said that. I mean, physical exercise is the key. I mean, even if you don't do anything else, I think physical exercise, make sure you get enough sleep, social interaction, these three things, there is no substitute for that. For anything in life, these are the three things that you need to do. So any of my patients also, before I start them on medication, I'll say, you do these three things and get back to me, and then I'll see if you need medicine. Because this actually sorts out most of the problems.
Yeah.
Dr. Sujay, I'd like to ask you another question, that you have highlighted a lot of some therapy options which are given in the group therapy format from a rehabilitation perspective, and some options that you've highlighted in your presentation could have individualized approaches as well. So how would you appraise the level of evidence that which of these interventions are more recommended in group format, and are there any specific interventions which you think could have higher evidence for individualized deliverance format?
Okay, so most of the behavior therapy that we have is mostly individual. I mean, so the therapies where you have a person interacting with another person using a behavioral approach is usually an individual format. The group formats are basically like a community-based system. So let's say if you take contingency management, or if you take community, if you take CRA, these are actually group formats. So even though they follow behavior therapy principles, they are obviously group formats. But there is no so let's say except that matrix model, which they have a group therapy session, which I told you. I mean, I'm not sure how that's very effective, because one, we don't have that in India. I have not seen that being used. I have not used it. I haven't seen anybody use that either. That has group therapy. Has been advised in that. But otherwise, you have most of these things are individual therapies. If you look at CBT, or if you look at mindfulness, they're all CBT. Or you have a group activity-based things like CRA, Contingency, or 12-step program, which is a group activity related kind of a thing. But of course, I mean, the group is tremendously great support. The group gives you so much of support that, I mean, the group is always better at supporting you when you think that you're going to have a relapse. So I'm a great believer in the groups being able to support you.
Thank you very much. So as I understand that you have highlighted that most of these are individualized interventions are more preferable as per your expertise. I'd also like to ask you, would you like to share any specific techniques that you find effective while dealing with the patients? Any individual techniques which you feel helps any particular condition at a very practical level?
So again, I mean, I'm guilty of not really practicing it. I'm sorry, doctor?
Like, if you could share a small example of one technique that you feel is very helpful in your...
So again, these are techniques that are practiced by my psychologist. So I'm guilty of not really doing this stuff. So the two things that we practice are, one is DBT and other is mindfulness. So which seems to be among the more popular and more effective methods, as I see it. This is from a practical perspective. I'm telling you from what I have seen. I mean, it could be different for other people.
So why the dropout rate is very high, sir? Dropout rate is very high. After how many sessions they will drop out?
Dropout rate is generally high, sir, because
of the financial constraints, or the unable to spend the time?
No. They I mean, because the desire to take the substance is so high, and lot of my old teachers used to tell me there is so something called addict personality. You see, it's not there in textbooks, but there is addict personality, and once you have that personality disorder, no matter what you do, at the end of it, you just go back, you just drop out of it. So when you think everything is fine, and you somebody who's been, I mean, it's just unbelievable how a person who could have everything in life but becomes addicted to a substance just would give up everything that is important to him, his family, his career, his job, his house, and everything, just to go and take the substance. So unless there is a personality disorder, why would they do that? Of course, I'm not subscribing to the idea, but it always seems like that. So dropout rates can be very, very high. Unless you catch these people fairly early, it is a very, very difficult battle.
Even it will be cumbersome to the family members also to bring
Absolutely.
to the...
Absolutely, sir. Absolutely. Absolutely.
Madam, do you want to share any experiences in de-addiction clinics or in de-addiction classes? Darpan, madam.
Sir, can you please repeat it? Can you please repeat your question?
You better to say if you have any experiences in the de-addiction, the behavioral treatments. If you have any experiences.
My current area of interest is within and psychotherapies are also an area of interest for me. What I understand is
problem started. So if there are no...
There's some disturbance from his 9848. May I request you to please mute yourself?
Resounding our own voice.
It's from that 98483419938.
Can you please mute yourself? 9848. Can the admin mute them, please? 9848.
98483419938. Yeah, he left.
He heard you, sir.
Thank you, sir, for your nice presentation. If you don't have any questions,
yes, sir,
we'll close the session.
All right. Thank you, sir.
Absolutely nice.
Thank you.
Thank you very much, Dr. Reddy, my co-chair, and Dr. Sujay. And I just wish to also thank Dr. Kishan sir and Dr. Vishala Kula for having me here to chair this session. It's been very nice, and thank you, everyone.
Thank you, Darpanji, for accepting the chairperson, and made it the session very live along with Ram Subba Reddy.
Thank you, Kishan sir, for giving me the opportunity. Thank you.
Thank you.
Thank you, Sujay sir, for accepting as a speaker.
Wonderful. I like your session a lot because I'm having some inclination toward this neurocognitive theories.
Okay.
Thank you. Thank you.
Okay, I will declare the session closed.
Thank you, sir.
Somebody has to unmute that podium mic.
We have given the memento for Ramsubba Reddy sir and Darpan Kaur ma'am. Jagannath sir has taken on behalf of Ramsubba Reddy sir, and Suresh Kumar sir has taken on behalf of Darpan Kaur ma'am. And for Sujay sir, we request Dr. Gangaram sir to take the memento. Minath sir, kindly give the memento to Gangaram sir.
Thank you very much.
Thank you, sir. Thanks a lot, ma'am. By this, we conclude our scientific session. In a while, our valedictory session will start. Thanks a lot, all the delegates, all the participants, all the speakers, all the chairpersons, and all those who are viewing us online. Thanks a lot for being with us, and it has been our pleasure to conduct this CME, and valedictory function will start soon. Thanks a lot.
Yeah, we will remain for valedictory function also.
Sure, sir. Sure, sir. Sure, sir.